Hi, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor of JAMA Network Open.
And I'm Mike Berkowitz, Electronic Editor for JAMA and the JAMA Network.
So, of course, as usual, if you're following along live, feel free to send us questions or your comments on Twitter, Facebook, or YouTube. Along with the live feed, you can just respond to the tweets on Twitter or ask us questions in the comments.
And if you have questions after we're live, after we've shut down, leave comments on any of those platforms, and we'll do our best to get back to you. We'll also post links to the articles that we discussed today.
Great. So going right into the articles we're discussing today, first one we have is Trends in Emergency Department Use by Rural and Urban Populations in the United States by Margaret Greenwood Erickson and Keith Coker. And we've got author Margaret Greenwood Erickson with us today.
Awesome. Welcome, Margaret.
Thank you. Thanks for having me.
Sure. Thanks. Glad you could join us. So basically, why don't you give us the brief rundown, the one-liner? What's your paper showing us?
Yeah, our paper is showing everyone that rates of emergency department use by rural populations are disproportionately increasing when compared to urban counterparts.
Over what time period?
So we studied the National Hospital Ambulatory Medical Care Survey between the years of 2005 and 2016. And that's the most recent data that they've released.
Interesting. And what was really interesting to me was that the urban ED changes just wasn't that impressive. It was really a pretty small increase in urban ED visits and a pretty sizable increase in rural ED visits per capita.
Yeah, absolutely. And I think that there's a lot of rhetoric around emergency department use and rising emergency department use. And certainly we are seeing that nationwide. But I think it is, there are a lot of implications about the fact that we're seeing in rural areas, when we do population adjusted measures, that we're seeing such large increases in rural ED visits, even in the fact that rural populations generally have been declining, though there's been some stabilization in the last few years.
So, and that's obviously an interesting finding, but I'm going to back you up. What was the rationale for asking the research question and doing the research effort? Did you have a focused idea about what you were looking for?
Yeah, absolutely. So as an emergency physician, I see firsthand how emergency department use patterns provide a lens into the status of healthcare delivery of the communities that they serve. And I've worked in both academic and rural emergency departments. My heart is really in rural emergency department clinical care. And, I've seen in rural emergency departments high use of EDs for unscheduled acute care needs. And, you've probably also heard about troubling declines in the health of rural Americans coupled with the rising rural hospital closure rate. And so those sort of combination of things had led me to have this hypothesis that rural populations might engage with their emergency departments in ways that are different than urban populations. And, as a whole, rural Americans are a health disparity population. They're a very heterogeneous group, but many, of them are health disparity populations. And so to me, it's critical to understand healthcare use of individuals in rural areas to gain insights into addressing rural health disparities. And my hope was that this information would help healthcare systems and policymakers to make data-driven decisions informing new models of care for rural healthcare delivery.
That sounds great. So kind of one of the questions that I had, you may have put it in the paper, is were there shifts in the actual availability of emergency departments? Did the numbers change? Were there mergers and acquisitions that kind of decreased the number? I know the numbers of patients went up, but I wasn't sure what kind of the actual infrastructure looked like over that period of time, whether there were changes in that as well. Maybe openings too. More opportunities to visit the ED.
There's been a rural hospital closure crisis going on for about the last 10 years. And it's been primarily occurring in southern states and states that did not expand Medicaid. And so overall, the number of emergency departments that would be hospital-based has been declining. And HAMC's, the National Hospital Ambulatory Medical Care Survey, the survey that we used and analyzed in this study, it doesn't allow any sort of granular state by state or geography by, very small geography evaluation. So it can't sort of speak to, when a hospital closed here, what happened. But overall, yes, the number of emergency departments would have gone down during this time period due to rural hospital closures.
Mm-hmm. Yeah, and you mentioned Medicaid, and I also found it interesting. Again, there's a lot of, I think, I don't know, common knowledge about a lot of these things that tends to be incorrect. And I just found it interesting how much the Medicaid visit rates increased in the urban areas. If we pull up the visual abstract, I have it highlighted here. First off, you can see just the difference in growth side by side, which is kind of startling. But the Medicaid rate growth from urban areas went from about 57 visits per 100 to 88 visits per 100 in urban areas, but in rural areas went from 56 to nearly doubling to 112 per 100, nearly a doubling of Medicaid. I mean, obviously, some of this is speculative. Do you think it's, how much of it do you think is the Medicaid expansion overall and people switching from uninsured to Medicaid, or people with Medicaid getting sicker or getting worse access?
Yeah, I think, to your point, I think it's hard to say for sure what is going on. We certainly know that after Medicaid expansion, that states with large rural populations who expanded Medicaid, those we saw the greatest gains in coverage. But there are many rural states, or many states with large rural populations that have, and generally in the South, that have not expanded. And so it is certainly possible that the increased coverage through patients gaining Medicaid in Medicaid expansion states could be, that might be probably what we're seeing, certainly in the urban areas, I would say, and very possibly in the rural areas as well. And we did see a commensurate decrease in the uninsured in both the urban and rural setting, speaking exactly to, your hypothesis that this could just be shifting.
Yeah, and as I'm sure you know, there's been a ton of papers looking at what's happened since Obamacare, and
Absolutely.
basically the main thing is a big switch where the uninsured ED rate dropped and got replaced by Medicaid, and it's basically almost 1-for-1 exactly.
Right.
Right.
So that's the elephant in the room. I'm not sure I read the curve. I think it's figure 2, figure 1 to show a real obvious effect of the ACA starting, say, in 2010. I mean, there's up and down.
Right.
But those are interesting trends. The other thing I was interested in is the failure to find a trend or a statistically significant trend in ambulatory sensitive conditions. Because that's where that's a nice concept. It's a nice idea that things like diabetes complications and pneumonia are things that if you can catch them in primary care, people don't need to go to the ED or be hospitalized. But you didn't see any changes there, right?
Not really. It was a very small increase, and it was pretty similar across urban and rural. I mean, I think one challenge, we obviously used ambulatory care sensitive conditions in our study, but it is a very blunt instrument. And it, I would say, can provide some insight into the infrastructure of primary care in areas where patients are visiting emergency departments rather than maybe going to primary care. But I think it is still somewhat of a blunt instrument. And so my hope is that in the future we'll have slightly more nuanced or detailed ways to identify true primary care capacity when it comes to looking at types of visits that are showing up to the emergency department. And the other thing is that, I would say from my own personal experience, rural emergency departments tend to be used a little differently than urban ones. In urban areas, if you're a primary care doctor and you have a patient who has an unscheduled acute care need, if you can't fit them in, you could always recommend they go to an urgent care. But in rural areas, urgent cares don't exist simply because the population is not there to support the financial model generally of an urgent care. And so the emergency department becomes in a lot of ways a de facto urgent care and a very important source of care there. And I think there's always this emphasis in healthcare, and it's driven a lot by insurers about reducing ED use at all costs. But rural emergency departments, I think, play this very critical role in actually providing a fair amount of unscheduled acute care when there's no other options. And I'm not entirely sure that our message should be stop using emergency departments, don't go there. Rather, I think it's let's think about how rural emergency departments can be integrated into local healthcare delivery.
Mm-hmm. Right. Yeah. I mean, we've seen a lot in the rise of freestanding EDs and urgent cares and retail clinics that, hey, look, this is this great opportunity to bring access to areas that don't have access for acute unscheduled care. Mm-hmm. But then that seems like rhetoric when you look at the data. There's a number of papers that show that those are built in places where they're profitable, places with higher socioeconomic status, higher concentrations of population, like you mentioned, and a lot of it has, I'd say, different missions than a lot of hospital-based emergency departments have.
Yes.
Right. I was going to ask you about kind of the retail clinic or the minute clinic climate nationally in these areas, but you raised the good point that they're there in the sense to bill insurers for kind of low acuity conditions.
Mm-hmm. Yep.
Yeah.
Yep.
Okay.
Yeah. Great. Well, thanks for joining us. Any final thoughts?
I don't think so. Thanks very much for having me, and I appreciate the opportunity to share our findings.
Yeah, thanks for the paper, and thanks for the work. Good stuff.
Yep, thanks for joining us.
See you.
Bye-bye.
What do you have next, Seth?
All right, well, since I get to pick the papers,
Yes.
we're doing another ED-based paper. This is the point-of-care ultrasonography in the diagnosis of retinal detachment, vitreous hemorrhage, and vitreous detachment in the emerging department by Shady Laham and colleagues.
Great. So that was just like a few weeks ago that we talked about point-of-care ultrasound for detecting pleural effusions in heart failure, right?
Yep.
So this is really trendy, and I think there have been calls for more evidence about the use of that technology, and usually there are those calls, but people use the technology anyway. That may be the case here, but we're seeing the evidence in our journals, which is great.
Yeah, and this is great, and this is fun because it's a relatively easy technology to use, and especially one of my favorite parts about point-of-care ultrasound is that once you start using it, it's really easy, and you basically already have the fixed costs taken care of. You already have the machines there. You already have some experience and skill, and it's really easy to translate into other use cases. So, like when I first started learning ocular ultrasound, it was pretty easy to add that to my practice.
So you're using it. What does it look like?
Yeah. So we've got a video. We stole it from YouTube. It's actually from Academic Life and Emergency Medicine, Michelle Lin's website, and it's pretty easy. Basically, the eye is a big ball of gel,
gelatin, right?
Yeah, which is like perfect for ultrasound use,
right.
as the invited commentary mentions, and it basically just looks like a sphere. You can kind of fan through it. You can see a couple different parts. The lens is always nice. You can show patients their lens. People like to see little details like that. And if there's a detachment, there's a defect in the posterior wall, and there's a range of findings, both from what I've seen in the research and in my experience. And sometimes it's just this big obvious thing. It's a slam dunk diagnosis, and sometimes it can be subtle.
Got it. So, and did you get training before you did that, or did you just pick it up and
I think
one, do one, teach one?
I would I say I got what is technically considered training.
Okay.
But with a lot of point of care ultrasound, one of the benefits is a lot of it is see a couple, do a couple, teach a couple.
Right.
To get the basic broad strokes of it.
Okay, so I have more questions, but let's talk about the paper.
Yeah, so the paper's good. So basically they looked at 4 hospitals in California. The authors out of Irvine, I think they also looked at UCLA and Loma Linda. They had 75 different docs and PAs across a range of residents and attendings, and basically it was any patient with eye complaints who some of our Twitter friends like Dr. Glaucomflecken would appreciate. Trauma patients were excluded. There's a whole thing about that.
Yeah. Okay.
And basically before, if there was any chance that it was a retinal detachment or a vitreous detachment or hemorrhage, they did an ocular ultrasound, and they basically, the research assistants had to ask them for the information before they talked to the ophthalmologist, and they used the ophthalmologist's evaluation as the gold standard. What's great about that is that that's not a true gold standard, but that's exactly what happens in practice.
Right, but the ophthalmologists aren't using point-of-care ultrasound themselves.
No, they're not using point-of-care ultrasound.
They're doing their full exam.
Yeah, they do a full exam. They do basically whatever the ophthalmologist wants to do on their evaluation. Right. Sometimes that includes some sort of ultrasound. My understanding is they use fancier, weirder ultrasounds that I don't understand, and not just like the big sonosite or whatever that I use. Right. But they just do what they want. A lot of it's fundoscopy. Some of it does tend to be ultrasound.
Yeah, I agree with you. That's a perfect reference standard. So this is kind of a standard issues diagnostic accuracy study, a new technology against the reference diagnosis.
Yep. And what they found, if you look at the table, was basically that ultrasound is pretty good. The point estimates are great. Sensitivity is 96.9%. Specificity is 88%, which is pretty good for retinal detachment. I'll be honest, vitreous hemorrhage and vitreous detachment aren't nearly as important as retinal detachment, so I kind of focus on that as the diagnosis. Plus, there's some comorbidity with these, and if you see a vitreous hemorrhage, they can still have a detachment, so you don't want to search satisfaction here. But the bad news is the confidence intervals were pretty broad. And basically the lower end of the confidence interval for sensitivity is only 80.6%, so only about 81%, which basically means that you're going to miss 1 in 5 actual retinal detachments, which means it's not good enough to get out of doing an ophthalmology consultation, which would be nice.
Right. So that was going to be my question. So the way I read these numbers is similar to the way I read those for the other paper, which is that this is a good technology, or maybe an adequate technology for excluding the diagnosis, but not for ruling in the diagnosis.
Right, exactly. But more importantly, it's not good enough to totally obviate getting the ophthalmologist on board.
Right.
For me, the basic use case is when I have a patient who's got like a pretty good story for detachment, I'm going to call the ophthalmologist, and I put the ultrasound on, and there's a big obvious flap. It turns it into a really easy phone call and helps me also prioritize, hey, by the way, this one's got a detachment. It's not just a story of floaters and flashers.
Right. Got it. So that's what I was really going to ask you, because if it's an adjunct, it's not a triage technology yet, right? It just allows you to convince the ophthalmologist to come down quicker. Right.
Yep. And I could also say I could see docs in more community-style practices where they're referring these patients to the ophthalmologist as outpatients, which is appropriate in a lot of cases. It helps say, hey, this is one, I've got a pretty big flap. This is one you might want to come in tonight. Or, you know what, I don't see anything. I know that's not perfect, but they'll be able to see you on Tuesday.
Okay. Yeah, so in terms of that follow-up and scheduling, okay, that makes sense. So it's a useful tool, but don't try this at home unless you have been trained, or what?
I think you can get some basic training. There's a lot of different venues to get training. There's probably, if you've got some basic ultrasound skills, there's probably both some ways you can read about it yourself or learn from others. But I think the big takeaway is the sensitivity is not good enough to totally exclude detachment. So you can't just use this, you can't watch a couple YouTube videos, throw it on someone's eye and say, nah, you're fine, you don't need to see the eye doctor. But again, I think it's a useful adjunct. And again, once you start doing point-of-care ultrasounds, you get pretty comfortable doing point-of-care ultrasounds. So it's not that hard to do one like this, especially where the anatomy is pretty easy.
Great.
Yeah.
Good study then.
Yeah, a little context. There were also right around the same time 2 other studies came out, including a systematic review and meta-analysis that basically say about the same thing, and the authors talk about that in here too.
Good. So, bread and butter clinical medicine and JAMA Network Open. I love it.
It's reproducibility, which is always nice.
Right.
And then I always like studies like this that basically reinforce what I thought before.
Right.
Where my LR is 1 and it confirms that I'm correct.
Right.
Okay.
What else was in this past issue?
Right. So there's a bunch of great stuff this issue. We're just going to do some quick hits from the table of contents.
Let me pause. I say issue, but we're not a print journal. We're online only. So an issue is just the number of articles that we release every Friday.
Right, exactly. So from this Friday, April 12th, we've got a bunch of great articles. From the top, ones they looked at complex cancer surgery at top-rated cancer hospitals and their community affiliates. So basically, when fancy big academic center has their community site that has the same logo, but it's different doctors in a different building. For these complex cancer surgeries, they looked at the outcomes, and the outcomes are actually worse in the satellite hospitals.
So that's really provocative, and I expected a small uproar over this paper, but I didn't hear anything over the weekend.
Right? Yeah,
Did you?
I didn't hear much. No, and it's kind of sad because there's been a lot of good stuff about how having these kind of affiliations offers a lot of promise for getting patients access to complex cancer care. We did a paper, I think it was back in November, on patients traveling or why they don't travel to the big meccas for the big central places for complex or for cancer care. There's all sorts of barriers: cost, travel, time, logistics, etc. And unfortunately, the fact that there does seem to be a difference in outcomes is almost, I don't know if alarming is the right word, but worrisome, concerning, less than good.
Right. So we're not prepared probably to dig in right now, but there's always ways, the objection that always comes is kind of risk adjustment, risk severity adjustment. We take care of different kinds of patients, and that accounts for apparently worse outcomes. So we encourage the conversation. Have it on our social channels or wherever you want to. But surely there's going to be a response to this at some point.
But I would say I was actually kind of shocked. If you had just given me the title and asked me to guess what the results were going to be, I would say, you know what, I bet the outcomes are the same, but is the risk adjustment the same? Are they selecting out the more complex patients to go to the big site? And that's not what happened. So,
okay.
Interesting. Next up, we got trends in the proportion of female speakers at medical conferences in the U.S. and Canada from 2007 to 2017. So there are some good signs here that medical conferences are having higher proportions of female speakers. We are getting closer to equity there, which is nice. Basically, from the beginning, it was about 1 in 4, and now it's up to about 1 in 3 speakers medical conferences, which is not equal, but is closer to what the proportion of overall female doctors is. So that's better. And not surprisingly, there's a disparity between medical and surgical specialties.
Right. So that's what I was going to say. Not to overthink it, but different specialties and subspecialties have different proportions of men and women. Women tend to exceed men in pediatrics. I think it's about 50-50 in internal medicine, making huge gains in surgery. They're huge in OB-GYN. Did they kind of weight it for the numbers of conferences by specialties based on proportions?
Yeah, they did a bunch of different stuff. I was just going to give some top line numbers for our quick hits.
They did some hand waving, yeah.
No,
anyways, we're making progress, and but we're not quite there yet.
Right. But I'm an optimist that things are getting better, but pessimist that things aren't good enough yet.
Okay, sounds good.
Yep. Next up, so this is an interesting one where they looked at PULSE, the physician orders for life-sustaining treatment. So basically, advanced directives that patients and their families fill out, and how different medical practitioners interpreted them, and basically looked at simple inter-rater reliability, so simple kappas, and found the kappas were pretty good, actually better than I would have guessed, in the low 0.9 range. So about 90% agreement, which is overall good. The downside is basically the way their numbers worked out, about 1 in 5 advanced directive order specifics, there was a disagreement between two providers.
And are these complex advanced directives, or do we know anything about that? Is it, give me IV fluids, but don't put me on a machine? Like, are there lots of variables, or is it like, just let me go?
Yeah, so to be honest, I'm not sure about the details in this study. In general, the ones that I see are pretty complicated. Like, I believe the standard Illinois one basically has 3 general levels, and you can always specify beyond that, but it's basically do everything, do nothing, or here's some kind of middle-of-the-road stuff. And there are definitely a lot of situations where it can be really tricky to figure things out. It's easy to say, yes, fluids, no antibiotics, no tube feeds, no breathing machine.
Right.
But obviously a lot of stuff, it's easy to get very complicated.
I think the only surefire advanced directive is the photo I saw either in New England or Journal of Medicine or Annals, like in the 90s, of a guy who had a thoracotomy scar and do not resuscitate tattooed all over his chest. Yeah,
there was probably a few months ago, there's actually a really interesting discussion I saw on whether or not providers should follow advanced directive tattoos. With basically
Is that right?
The pro argument being, if you go out of your way to get a tattoo that says do not resuscitate, then you've taken some steps. You're showing some action here. The flip side is like, what if the patient changed their mind? It's really like, what if they changed their mind last week and didn't get the tattoo removed yet? Or, like, it gets more complicated than it seems. I like the one. There's one. It's on Google Images where it's not just do not resuscitate. It's like a form with signatures tattooed.
The whole form is on there.
Yeah. And I'm sure this is an urban legend, but I heard once where somebody they went to go put pads on someone and there's a tattoo on the front, and they went to the side and there's one on the side too.
Well, that's a smart patient. Okay.
Yeah, we'll see. Or an urban legend, either way.
Or an urban legend.
All right. Next up, this is an interesting study where they looked at basically how the public judged the trustworthiness of physicians since the CMS open payments disclosure database came out.
Okay.
So basically the whole idea is, hey, we know some docs are taking money from industry. There is some shadiness there. Medicare started this big database of saying
2012, I think, was the first listings.
Yep. And the idea is basically if we're open and transparent, then there'll be better trust, and we can know. And it turns out that trust went down since then.
Yes, I would have predicted that.
Yeah.
Based on what's going on in the world.
Yeah, I mean, obviously there's a bunch of other parallel trends happening at the same time.
Yes, parallel trends, and there have been some high-profile physicians who have neglected to report all of their industry payments.
Yep.
If you read the New York Times and other kind of big papers, it's been an issue.
Yep, exactly.
Doesn't reflect well on us, so we at JAMA and the JAMA network are always trying to get it right if we can. But by and large, most docs are honest.
Yep. That's the big thing. I think a lot of this is outliers. I think it's kind of like opioid prescribing, where a lot of us, hand-wringing about is someone going to come after us for writing scripts for ankle sprains or whatever it is. And again, it's the guy selling stuff, huge prescriptions out of their vans that are the big offenders for the actual fraud.
Right.
But again, openness is a good step, but as the ethicists tell us, that's not nearly enough. It's just a start in the right direction.
Okay.
All right, next up, this is we have to do opioids, of course. So factors associated with opioid use in patients hospitalized for acute pancreatitis.
Okay.
So this is basically patients with acute pancreatitis admitted to the hospital, very painful condition. Basically, one of the biggest argument cases to actually acutely use opioids.
Right.
And not surprisingly, there's huge variation in use.
Got it.
They looked at a bunch of different hospitals. Not only there's hospital variation, so a lot of kind of local practice pattern variation, but also some trends like patients who are older were less likely to get opioids, which is not surprising.
And you're giving me a flashback to medical school where I was taught never use meperidine in a patient with pancreatitis because it led to constriction of the duct that would increase their pain.
So you've got that backwards. So you're not supposed to use, you're allegedly used to not supposed to use morphine. That was one of the arguments to use meperidine, I believe, because of sphincter of Oddi spasm from morphine.
Yes, correct.
That was one of the arguments for meperidine.
Yes.
But basically, since then, we've decided that a better rule is never use meperidine.
Okay, and why is that? That's
basically it has a ton of side effects. It's more addictive. It's more euphoric. I believe it basically acts as an MAOI or I inhibitor. So it interacts with a ton of drugs. The Libizion case, where a patient in New York unfortunately died after getting a mix of, I believe it was meperidine and haloperidol, and I think got unrecognized serotonin syndrome from that, is why we have work hour restrictions now.
Oh, I didn't realize that.
I might be fudging some of those facts, but if I recall correctly, that's how it happened.
Why show up to learn?
Yeah, but basically, meperidine bad. I don't think I've seen it even talked about in actual clinical practice outside of a protocol for shivering and therapeutic hypothermia since I've started.
Got it. And just to go back, so acute pancreatitis tends to be drugs, gallstones.
Yep, alcohol.
Alcohol, right. But alcohol is often can be chronic pancreatitis also.
Yep. Okay. And also something, if I remember correctly, about a third of acute pancreatitis or acute pancreatitis cases are idiopathic, and there's no good reason.
Right.
They did find that patients who had alcoholic pancreatitis were more likely to get morphine. Maybe that's one of those things where we have that script where they have pancreatitis, it's from alcohol, we know that's painful and are more likely to give it, or maybe there's, I don't know, receptor modulation stuff, things like that. But also, sadly and unsurprisingly, there was also decreased analgesia in underrepresented minorities and Asian populations.
Okay.
Yeah.
Well, so something to work on.
Yeah. More opportunities for improvement.
Right.
And lastly, not from the release overall, but from what I'll talk about today is Dr. Stanton Glanz looked at what would happen in Medicaid expenditures if cigarette smoking prevalence was reduced by 1%. And basically what that meant is in 1 year, we'd save $2.6 billion, which is a lot of money, and about, 1.2% of all Medicaid expenditures off the top of my head, something like that, by decreasing, how much we spend on smoking, or how much we spend from the complications of smoking. And also Medicaid, for lots of reasons, patients who have less money, et cetera, are about, from his data, about 1.75 times more likely to smoke than the general population. So a 1% decrease is a pretty big decrease.
Cool. And Stan Glantz is an evangelist for, well, I don't know if you can say that, for anti-smoking measures in the United States.
It turns out smoking is bad for you.
Yes, and you may not know this, but he was a young NASA engineer on the Gemini missions in the 1960s.
Really?
So he helped design the lunar capsules or the modules or the wiring or something before he went to medical school.
That's pretty cool.
Yeah, so he has some interesting stories to tell about that.
Nice. And I know a couple emergency docs who are astronauts now.
For real?
Yeah, for real.
Okay.
One of them's Canadian, though, so I don't know if that counts.
Well, and JEMMA Network, particularly JEMMA Neurology and Ophthalmology, have an in with some of the NASA scientists and been publishing a lot of clinical science about changes in the brain and in the eyes that occur with long-term space exploration, I guess. Being out in space for a while, they've done a lot of physiologic measurements, and they're beginning to define, I think it's called the space ocular neurologic syndrome or something of that sort. So check out our pages, search for SPACE, space, in JEMMA Network.
Yeah, and a few years ago, I think it was at Dulles Airport in DC. There was, one of those little museum exhibit things in the airport. They had a thing on how they were using telemedicine to teach astronauts how to do point-of-care ultrasound.
Oh, really?
Because, you usually don't have doctors in space, so it ties everything together really well.
Jim Lowell knows that from Apollo 13, right? Okay.
All right. Well, great. That's all we've got for today. Of course, go to JAMANetworkOpen.com. You can read these papers and more for free. They're all open access. You can download pretty PDFs and everything. This is from last release. The next release will be coming out Friday at 10 a.m. Central Time, which is something.
We think it's GMT -5. Check out our podcast. Check out our title and key points translations into Spanish and Mandarin Chinese.
Great. And join us next week.
Thanks for joining us. Leave comments, and we'll see you soon.
Great.
Bye.
Take care.